Now we are going to discuss prostate and seminal vesicle. Prostate and seminal vesicle. Okay. First of all, we are going to discuss the anatomy of prostate. In prostate, there are zones, and those are known as McNeil zones. So first, have a look. What are the McNeil zones of prostate? McNeil zones. Okay. So see the anatomy first. This is urethra. Around urethra, there is periurethral muscle. So urethra and periurethral muscles. Then there is a zone surrounding urethra. This is known as transition zone. Centrally, there is central zone, and peripherally, there is peripheral zone. Right? So these are the zones. And what is this? This is anterior fibromuscular stroma. So this is transition zone, this is central zone, this is peripheral zone, and this is anterior fibromuscular stroma. Right? This is the classification which is being followed nowadays. But previously, prostate was divided into various lobes, and sometimes questions are asked related to those lobes. What are those lobes? See, suppose we are going to take sagittal section, and if you are taking the sagittal section, what are the lobes in prostate? So on sagittal section, if you see, this is the bladder, this is the prostate, and this is the urethra. Here you can see this is the ejaculatory duct which is going to open into prostatic urethra. So this is the prostatic urethra. Clear? So what are the lobes? Here you can see that this is what? Anterior lobe, this is what? Posterior lobe, and this is what? Median lobe. So there is anterior lobe, posterior lobe, and median lobe. In sagittal section, you cannot see two lateral lobes. So how many lobes are there in prostate? Total 5 lobes. So what are those lobes? So here you can see anteriorly there is anterior lobe, posteriorly there is posterior lobe, there are 2 lateral lobes, and there is median lobe. So how many lobes are there? There are 5 lobes in relation to prostate. Now the questions which are asked. First question, that what is the most common site of BPH? The most common site of BPH is transition zone or median lobe. What is the most common site of carcinoma prostate? That is peripheral zone or posterior lobe. So questions which are asked related to this anatomy. First, most common site of BPH. Clear? So this is transition zone or median lobe. Right? Most common site of carcinoma prostate, and that is peripheral zone or posterior lobe. Okay. Now see, this anatomy is very important to understand certain basics related to the diseases of prostate. Okay. Imagine that this patient is having what? BPH, benign prostatic hyperplasia, BPH, and in that BPH, imagine that this patient is having one nodule here. This is the green colored nodule, right? And patient is having another nodule here, this blue colored nodule, right? If you notice this green colored nodule, it is very close to urethra, but the blue colored nodule is far away from urethra, right? Now, since the green colored nodule is closer to urethra, despite of its smaller size, what happens? It can lead to symptoms. Symptoms of what? Obstruction of urethra. It means one point is clear, that there is no correlation between size of prostate and severity of symptoms in BPH. Even if a large nodule is there which is farther from urethra, patient might be asymptomatic, and even if a small nodule is there which is very close to urethra, patient might be symptomatic. One principle. Second principle, you know that the most common site of carcinoma prostate is what? Peripheral zone. This is peripheral zone. So since the most common site of carcinoma prostate is peripheral zone, you can see the nodules or these malignant nodules are farther from urethra, not in close relation, and that's why majority of patients of carcinoma prostate are asymptomatic in initial stages. Patients are asymptomatic in initial stages. Okay. Third principle, you must be knowing that for BPH we perform TURP. What is TURP? Transurethral resection of prostate, and in that case the tissues are being removed from which zone? The tissues are removed from transition zone. Okay, so we are going to remove the tissues from transition zone. So the question is asked whether TURP is protective or not for carcinoma prostate. So TURP is not protective. Why? Because peripheral zone is not removed. So another principle, TURP is not protective for carcinoma prostate. You must be knowing how we are going to screen the patients of carcinoma prostate. So for carcinoma prostate, the screening is performed by DRE, digital rectal examination plus PSA. So even after TURP, DRE plus PSA should be continued or not? It should be continued. Why? Because TURP is not protective for carcinoma prostate. So these are the basic principles which are related to anatomy. Okay. So important point, there is no correlation between size of prostate, right, and severity of symptoms. First principle. Second, TURP is not protective. TURP is not protective for carcinoma prostate. Majority of patients of carcinoma prostate, CA prostate patients, they are asymptomatic in initial stages. Why? Because the location of nodule is in the periphery or in the peripheral zone, and even after TURP, the screening should be continued. The screening should be continued with DRE plus PSA. Then sometimes in Viva, examiners are going to ask you that suppose you are performing digital rectal examination, which lobe of prostate is normally felt and which lobe is felt when it's enlarged. So whenever we are performing digital rectal examination, the posterior lobe is normally felt and the median lobe is felt only when it's enlarged. Okay, so on digital rectal examination, this posterior lobe, it's normally felt, and the median lobe, it's felt when it's enlarged. It's felt when it's enlarged. Now in detail we are going to discuss BPH, that is benign prostatic hyperplasia. So this BPH is age related, endocrine controlled, multifactorial process. So this is age related, endocrine controlled and multifactorial process. Multifactorial process. Okay, so first see how it's age related. If you see the age 41 to 50 years, in this particular age group 20% patients have BPH, right? So if the age is 41 to 50 years, what is the incidence? It's 20%. And if the age is 51 to 60 years, now see how much is the incidence? It is 50%. And whenever the age of patient is more than 80 years, how much is the incidence? It is 90%. So if the age is more than 80, how much is the incidence? 90%. It is endocrine controlled. Endocrine control means it is under the influence of which hormone? It is under the influence of testosterone. Clear? So what is the problem in BPH? There is formation of nodules, and what is the most common site? Most common site is transition zone. So the BPH most common site, and that's transition zone. Okay, see the problem and the pathophysiology. So here you can see this is the normal prostate, and in this case, can you see there is formation of these nodules, and because of formation of these nodules, what is the problem? There is compression of this urethra. Okay, we are supposed to discuss first the pathophysiology. Let me tell you, whole pharmacology of BPH is dependent on this flowchart. Right? See, suppose this is a nodule in the prostate, and from this nodule I'm going to take cut section. So I'm going to take cut section from the nodule of prostate. So what are the components? If this is a nodule and I'm going to take cut section, there are two components. First is there is epithelium and stroma. Right? What are the components of stroma? In the stroma there is collagen and smooth muscle. So there is collagen and smooth muscle. Simple. We discussed that prostate is under the influence of testosterone and the BPH is under the influence of testosterone. You must be knowing that this testosterone is not an active substance. It has to be converted into 5-dihydrotestosterone, which is an active substance, and by which enzyme? 5-alpha reductase. So testosterone should be converted into 5-dihydrotestosterone, and the name of enzyme is 5-alpha reductase. Clear? And this 5-dihydrotestosterone, it's having positive effect on epithelium, means stimulatory effect on epithelium. Now see, if in BPH there is major component, what epithelial component is major, in that case what you can go for, or what you can use a drug which can inhibit what? 5-alpha reductase. So if epithelial component is predominant, in those cases we can use 5-alpha reductase inhibitors. Clear? Second principle, prostatic stroma is having rich adrenergic nerve endings. So whenever this stromal component is in majority, or when this component is predominant, here I can use what? Alpha blockers. So alpha blockers can be used, and what? These are going to relax the smooth muscles. Clear? So if epithelial component is predominant, we can use 5-alpha reductase inhibitors, and whenever this smooth muscle component is predominant, we can go for alpha blockers. Right? What is the problem with 5-alpha reductase inhibitors? See, suppose today I'm going to start 5-alpha reductase inhibitors. What is the problem? Yes, there is already some amount of 5-dihydrotestosterone which was formed initially. So until and unless the whole 5-dihydrotestosterone is going to be finished, what? The action of 5-alpha reductase inhibitors won't be predominant. It means minimum time required to act is 1 month for 5-alpha reductase inhibitors, and maximum effect is seen after 6 months. This is one of the biggest disadvantages. So what is the problem with 5-alpha reductase inhibitors? Minimum time required to act, and that's 1 month, and maximum effect, this maximum effect is seen in 6 months. Simple. What is the biggest advantage of alpha blockers? That this is instantaneously active. Clear? So you give alpha blockers, what it is going to relax the smooth muscles and symptoms are improved. So if we have to choose one out of 5-alpha reductase inhibitors and alpha blockers, obviously which one is preferred? Alpha blockers are preferred over 5-alpha reductase inhibitors. Because of BPH, there are certain changes into the bladder also. What are the changes? See, this is bladder. Okay, this is prostate. Just to explain, I'm going to make prostate bigger, and this is urethra. right? Here you can see that this is the prostatic urethra, right? Now we discussed that in BPH there is formation of nodules. So can you see here, these are the nodules, and because of these nodules what happens, there is compression of urethra, right? So what is the problem? See, suppose you are holding a dumbbell in your hand and you are doing exercise like this. So what you are doing, yes, your muscles are going to contract against the resistance, and that's why what happens, there is hyperplasia, sometimes there is hypertrophy. So here also the bladder is doing same thing. What it has to contract against the resistance, and if the bladder has to contract against the resistance, there will be hypertrophy and hyperplasia in the muscle of bladder. And what's the name of muscle of bladder? It is detrusor muscle. So what's the problem here? You can see that in detrusor muscle what happens, there is hypertrophy, there is hyperplasia. So there is detrusor muscle hypertrophy, there is detrusor muscle hyperplasia. What are the other changes seen? There is collagen deposition and there is fibrosis. So there is collagen deposition and fibrosis. These are the secondary changes in the bladder, and these secondary changes are responsible for irritative symptoms. So what are those secondary changes? Secondary changes in the bladder. There is detrusor muscle, hypertrophy and hyperplasia. There is collagen deposition and fibrosis. So collagen deposition and fibrosis, okay? And these secondary changes are responsible for irritative symptoms. Clear? Because of the nodules in the prostate, what happens, there is obstruction of urethra, and because of obstruction of urethra what happens, there is obstructive symptoms. So whenever there is obstruction of urethra, what are the obstructive symptoms? First, there is hesitancy. Hesitancy means hesitation in initiation of micturition. Then there is intermittency. The flow is not continuous, it is intermittent. Then there is poor stream and poor flow because of obstruction. There is dribbling of urine. There is post residual volume. So all these are obstructive symptoms. So two group of symptoms. First, obstructive symptoms. So there is poor flow, poor stream, there is hesitancy, there is intermittency, there is dribbling of urine, post residual volume. So patient is having this kind of feeling that urine is still left in the bladder, that is incomplete evacuation, right? And what are the irritative symptoms? You can easily remember by the mnemonic fun. So if the patient is having irritative symptoms, patient is having fun. Fun. Clear? So F means frequency, urgency, nocturia. So these are frequency, urgency and nocturia. Clear? So obstructive symptoms and irritative symptoms. On the basis of symptoms of BPH, there is a scoring system known as IPSS. What is the full form of IPSS? International Prostatic Symptom Score. So there is scoring system known as IPSS on the basis of these symptoms, and the full form is International Prostatic Symptom Score. This score varies from 0 to 35, and it is classified into three categories: whether patient is having mild symptoms, moderate symptoms or severe symptoms. So if it's mild, the score should be between 0 to 7. If it's moderate, the score should be 8 to 19, and if it's severe, the score should be 20 to 35. Clear? Now we discussed that it is age-related endocrine control multifactorial process. So generally, you will see the patients who are in the age group of 60 plus, they are coming to your OPD with these kind of symptoms. So imagine a patient whose age is around 60 and is coming to my OPD with all these kind of complaints that I'm having nocturia, I'm having incomplete evacuation, I'm having intermittency. In those patients, what I will do after taking history, I will perform what examination? Which examination? Digital rectal examination. So if I'm going to perform digital rectal examination, what are the findings in BPH? There is smooth elastic enlargement of prostate. And what are the findings in carcinoma prostate? In carcinoma prostate is enlarged obviously, but it's hard and there is median sulcus obliteration, right? So in patients we perform digital rectal examination, and what are the findings in BPH and what are the findings in carcinoma prostate? Okay, so in BPH there is smooth elastic enlargement, but in carcinoma prostate, its prostate is enlarged and hard. It's hard with median sulcus obliteration. So there is median sulcus obliteration. Okay, right? Second problem, we discussed that there is no correlation between size of prostate and severity of symptoms. So there might be one possibility that on digital rectal examination prostate is enlarged, but what? The patient might not be symptomatic. So it's the location of that nodule which is compressing the urethra that's more important. It means only digital rectal examination is not diagnostic. So what you have to document? You have to document the compression of urethra or obstruction to urine flow. So how you are going to document that? You can easily document that after measuring the urine flow. So how you are going to measure the urine flow? The name of investigation is uroflowmetry. Uroflow means urine flow, metry means measurement. So how we are going to make the diagnosis? We go for investigations, and which one? We perform uroflowmetry, right? So we are going to measure the urine flow. In this uroflowmetry, we have to calculate maximum flow rate, and which is known as Qmax. So we are going to calculate the Qmax. This maximum flow rate should be more than 15 ml per second. You have to remember, normally it's more than 15 ml per second. If Qmax is 10 to 15 ml per second, it is equivocal. And when this Qmax is less than 10 ml per second, this is suggestive of obstruction, right? I said Qmax less than 10 ml per second is suggestive of obstruction. I didn't say it is diagnostic of obstruction. Why? Because in BPH also Qmax can be less than 10 ml per second, and the patients who are having neurogenic bladder, in that case also it can be less than 10 ml per second. What is the problem in neurogenic bladder? First, see BPH. In BPH there is obstruction, but bladder is contracting against the resistance. So bladder pressure is very high, but Qmax is low. In neurogenic bladder, there is no force and pressure in the bladder. There is no force generated by bladder, so there is no pressure. And because there is no pressure, what happens? Qmax is low. So the basic difference between BPH and neurogenic bladder is what? The bladder pressure. So how we can easily differentiate these two conditions, BPH and neurogenic bladder? We can measure the bladder pressure. So how you can measure the bladder pressure? The name of investigation is cysto means bladder, metry means measurement. So how to differentiate BPH from neurogenic bladder? We go for cystometry. And on cystometry, if the bladder pressure is more than 80 centimeter H2O, yes, So if bladder pressure is more than 80 centimeter H2O, it means it is BPH. So in Comet Kill long back, one question was asked, what is the diagnostic criteria of BPH? So what's the diagnostic criteria of BPH? Qmax less than 10 ml per second and bladder pressure more than 80 centimeter of H2O. So this is the diagnostic criteria of BPH. And when the diagnosis is confirmed, we have to start the treatment. And which treatment is preferred? Obviously, it's the medical management. In medical management, we discussed which drugs are preferred. Alpha blockers are preferred over 5-alpha reductase inhibitors. Why? Because these are instantaneously active. So, diagnosis is confirmed. So, we have to start the treatment and we start medical management. Clear? So which drugs? We start alpha blockers. So what are the various drugs which can be given in patients of BPH? The drugs which we use is prazosin, terazosin, doxazosin. In DNB, there was one question related to new drug, silodosin. You have to remember. So this was asked in DNB. Silodosin. Clear? And which one is preferred? It's tamsulosin. Why? Because it is alpha 1A selective blocker. So most preferred is tamsulosin. Why? Because this is alpha 1A selective blocker. And what is the name of tamsulosin? The brand name? The brand name is Urimax. So whenever patient is going to hear the name of this drug, Urimax, patient is happy that I will do maximum urine everywhere. Maximum urination, Urimax, right? And generally the dose is 0.4 mg ODHS, 0.4 mg ODHS. So this is most commonly used. The second group is 5-alpha reductase inhibitors. 5-alpha reductase inhibitors. So what are the names of drugs which are used? Here we use finasteride, dutasteride and triptorelin palmoate. Finasteride, dutasteride and triptorelin palmoate. Clear? In certain patients, we give combination also. You must be knowing that there is a drug available in the market by brand name Urimax D. Urimax means tamsulosin, D means dutasteride. So third strategy is we give combination of alpha blockers plus 5-alpha reductase inhibitors. And this question is asked in exams. In which cases we give combination? The patients who are having large prostate and high value of PSA. Okay, high value of PSA. See, in majority of cases, medical management is sufficient, but there are certain indications of surgical intervention. First of all, there is no improvement after medical management. So what are the indications of surgical intervention? So first, no improvement after medical management. Second, if the patient is having recurrent UTI, so recurrent urinary tract infections, patient is having hydronephrosis or renal failure, there is presence of bladder stone. Why? Because BPH is causing obstruction leading to formation of bladder stone. So there is bladder stone, gross hematuria, and there is refractory urinary retention. Refractory urinary retention. Clear? This question is frequently asked. It was asked many times in AIMS. So these are indications of surgical intervention. After that, important point, what is the gold standard surgical treatment for BPH? And the gold standard surgical treatment for BPH is TURP. TURP means transurethral resection of prostate. So we are going to discuss surgical interventions. First of all, TURP is the transurethral resection of prostate, and this is the gold standard surgical treatment for benign prostatic hyperplasia. What we are going to do in TURP, transurethral resection of prostate, how it's done? So here you can see that in TURP we are using resectoscope. Okay, so with this resectoscope we are going inside the urethra. Okay, and within this resectoscope there is a wire loop or dithermy loop or helix evacuator, right? So what happens, with the help of this wire loop or dithermy loop or helix evacuator, we are going to remove the chips of tissue. So here you can see we are removing the chips of tissue and we are clearing the obstruction. So this is transurethral resection of prostate. I remember a story. I was sitting in OPD and then one partially educated patient came to my OPD, right? He was around 60. He said that, sir, my potato is enlarged. What he wanted to say, somebody told him that his symptoms are because of enlarged prostate and he forgot the term prostate. So he was telling me that, sir, my potato is enlarged. And then I told him that don't worry, I will take out chips from your potato, right? So we are doing nothing in TURP. We are just taking what chips of tissues. So whenever we are taking these chips of tissues out with the help of dithermy loop or helix evacuator, what happens? There is bleeding from these areas. And whenever there is bleeding from these areas because of opening of vascular channels, we have to go for continuous irrigation. So the irrigation should be going on. And what is the fluid used? It is 1.5% glycine. So these are the questions which are asked frequently in relation to TURP. See the important points related to TURP. So first of all, what are the techniques used for TURP? There are two techniques which are commonly used. One is Nesbitt technique. Nesbitt technique. This is not Nesbitt operation. Nesbitt operation is performed for Peyronie's disease. This is Nesbitt technique. And second is Maur-Mayer technique. Maur-Mayer technique. Okay, which one is preferred? Nesbitt technique is preferred. First important point, what is the fluid most commonly used fluid for irrigation? So for irrigation we use 1.5% glycine. For irrigation we use 1.5% glycine. In AIMS, this question was asked that whether we can use normal saline during irrigation or not. Be careful, it depends which type of cautery you are using. See, in majority of cases in TURP, we use monopolar cautery. What is monopolar cautery? You have seen in OT that we are using a grounding pad or cautery pad, black colored pad, over the back or in the gluteal region or in thigh. We are using that cautery pad or grounding pad. And for this monopolar cautery, there is a pen-like instrument. And what happens? For completion of circuit, electricity has to flow in the patient's body also. So if we are using this monopolar cautery and we are using electrolyte solution like normal saline, it will be broken into sodium and chloride. And what is the problem? With use of monopolar cautery, since the fluid is broken into ions, sodium and chloride, these ions are going to dissipate current locally. So it won't be that effective. So electrolyte solution should not be used with monopolar cautery. But you can easily use these electrolyte solutions with bipolar cautery. What happens in bipolar cautery? You have seen that it is forceps-like instrument and there is short circuit between the limbs of this forceps. Whenever you are using this bipolar cautery, there is local flow of current, right? So here there is short circuit between these two limbs. So here you can use the normal saline. So with monopolar cautery, we don't use normal saline. normal saline, it should not be used. There is a term known as TURIS. So what is the full form of TURIS? This is TURP in saline, with the help of which cautery? Bipolar. So this is TURP in saline with bipolar cautery. Okay, another point which is very important in BPH and TURP, and that is the landmark. What is the most important landmark, distal landmark in TURP, and that is verumontanum. Now see the anatomy. Now see, this is the bladder, this is the prostate, and this is the verumontanum. If you see the relation of this verumontanum, it is just proximal to this sphincter. And what is this sphincter? This is external urinary sphincter. This is external urinary sphincter. Clear? There is internal urinary sphincter also. So this is internal sphincter. And here for internal sphincter there is no landmark. What is the most important distal landmark? That is this verumontanum, because it is located just proximal. It is located just proximal to the external urinary sphincter. Whenever we are removing the chips of tissues, we are not going beyond verumontanum. Why? Because we want to protect the external urinary sphincter. But I told you there is no landmark for internal urinary sphincter. So what is the most important distal landmark? The most important distal landmark is verumontanum, because it is located just proximal to external urinary sphincter. Now see, the complications are related. How the complications are related? The most common complication of TURP is retrograde ejaculation. So see the complications. Complications of TURP, right? The most common complication is retrograde ejaculation. It is seen in 75% patients. Second is impotence. Impotence is seen in 10% of patients. And third is incontinence. Incontinence is because of injury of external urinary sphincter, which is very rare. So here you can see the most common complication is retrograde ejaculation. So what is the logic? It's very easy to understand. See, you can see here that this is bladder, this is what prostate, and this is what urethra, this is what ejaculatory duct, this is what vas deferens testis. You must be knowing that erection is because of parasympathetic system and ejaculation is because of sympathetic system activation. Okay, at the time of ejaculation, what happens? Can you see the semen via these ejaculatory duct? It's going into prostatic urethra, and via this prostatic urethra, it's going out via urethra. What happens at the time of ejaculation? There is internal urinary sphincter. This is under control of sympathetic ganglia, which one? L1. So at the time of ejaculation, it's closed. So it is closed, and that's why the semen is going anteriorly out via urethra. Since there is no landmark for internal urinary sphincter, so that's why what happens in TURP, this internal urinary sphincter is injured, and when this internal urinary sphincter is injured during ejaculation, what semen goes out, but some amount of semen also enters into the bladder. Why? Because this sphincter is not closed, and since semen is going against the flow, this is known as what? Retrograde ejaculation. This retrograde ejaculation is a complication of TURP, but it can be seen in other conditions also. Like in Burgess disease, we perform lumbar sympathectomy, and in lumbar sympathectomy, which ganglia is removed? Generally L1 to L4. If we are performing bilateral lumbar sympathectomy, removing L1 to L4 sympathetic ganglia, in that case what happens? In that case also retrograde ejaculation can occur. To prevent this, whenever we are performing bilateral lumbar sympathectomy, at least L1 should be preserved from one side. Third, this internal urinary sphincter is a smooth muscle. So any drug which can relax this smooth muscle, retrograde ejaculation can be a side effect, like in alpha blockers. These are going to relax the smooth muscle, and retrograde ejaculation is a side effect. Clear? So this retrograde ejaculation can be seen after TURP. It can be seen after bilateral lumbar sympathectomy and after use of alpha blockers. Clear? Long back in All India, Toughest All India 2012, this question was asked that what is the most common late complication? And the most common late complication is bladder neck stenosis. So late complication. So read the question carefully. Most common late complication is it's bladder neck stenosis. In how many cases? It is seen in 4% cases, followed by urethral stricture. Urethral stricture. And this is seen in 3.6% cases. Clear? There is another complication. Let me tell you, whenever we were senior residents, so generally TURP is performed by urologist or consultants. So whenever consultant is going to start the surgery, he is going to tell me that, or tell the senior residents that please note down the time. Whenever 90 minutes are completed, just tell me or inform me, I will stop the surgery. So why this concept of 90 minutes? See, in TURP you are removing the chips of tissues, so the vascular channels are open and continuous irrigation is going on with the help of 1.5% glycine. So since vascular channels are open, and if the surgery is performed for longer duration of time, what will happen? There will be absorption of irrigating fluid, and that irrigating fluid will be absorbed via the vascular channels, and what will happen? It leads to the fluid overload, and this is known as what? TUR syndrome, water intoxication. And since there is fluid overload, what patient is going to suffer from? Dilutional hyponatremia. So this complication is known as TUR syndrome. So the another complication which is known as TUR syndrome, the other names of this complication, it's water intoxication. Water intoxication. It is also known as dilutional hyponatremia. Clear? So what are the risk factors? Size of prostate more than 75 grams. Remember this size, this is very important. And second, duration of surgery more than 90 minutes. Right? It is very easy to remember the symptoms, and it's very easy to remember the management. See the problem. What is the problem in this case? There is water intoxication, means fluid overload. So whenever there is fluid overload, this patient will be having hypotension or hypertension. Obviously hypertension. And there is what? Dilutional hyponatremia. So because of hyponatremia, patient is having dizziness, confusion, visual abnormalities, bradycardia. So what are the symptoms? Because of fluid overload and hyponatremia, there is dizziness, there is confusion, there is visual abnormalities, there is bradycardia and hypertension. There is fluid overload, so there is hypertension. In medicine, you have seen many patients of fluid overload or volume overload, and generally in those patients, what is the drug of choice? We give diuretics. Which one? Furosemide. So here also the drug of choice is furosemide. We have to take out the extra fluid from the body. One, even after using furosemide, if patient is still symptomatic, it means the symptoms are because of hyponatremia. So how you are going to correct hyponatremia? What is the fluid of choice? Hypertonic saline, where we are using what? 3% saline. So the management in these patients, the drug of choice is furosemide, and even after use of furosemide patient is still symptomatic, then what is the fluid of choice? And the fluid of choice is 3% saline, and that's hypertonic saline. So this is how we manage TUR syndrome. Certain patients are coming to us with BPH saying that, sir, my prostate is of 20 grams only and I don't want to go for TURPY because after that there is impotence, retrograde ejaculation. So is there another treatment option, surgical treatment option? So yes, if the size of prostate is relatively smaller, up to 20 grams, we can go for TUIP. What is TUIP? TUIP is transurethral incision of prostate. So imagine that this is a urethra, yes, and there is transition zone. So what we do, we have to give 2 incision over this transition zone so that the effect of constriction is lost and obstruction is relieved. So this transurethral incision of prostate is done for small prostates size up to 20 grams. So the second treatment option is, it's TUIP, transurethral incision of prostate, and this is performed for prostates up to 20 grams. What is the name of knife which is used? Here we use Collins knife. Collins knife. And how many incisions are given? We give 2 incisions, one at 5 o'clock and one at 7 o'clock. So the position of incision, one at 5 o'clock and one at 7 o'clock. This is the position of incision. What is the advantage? Since in these cases the sphincter is not injured, so there is no complication of retrograde ejaculation, impotence and incontinence. Third, certain patients who are coming to us, their prostate is very large and the size is more than 75 grams. Some patients are having complications related to obstruction, like patients are having bladder stone and bladder diverticula. In these cases, we go for open prostatectomy. So what is the third option? We go for open prostatectomy. Okay, and what are the indications for this open prostatectomy? We discussed size of prostate more than 75 grams. If the patient is having bladder stone or patient is having bladder diverticula, right? What are the names of open prostatectomy? These are also asked frequently in the exam. So the names, first is Freyr's suprapubic. Freyr's suprapubic prostatectomy. Second is Millin's retropubic prostatectomy. So Millin's retropubic prostatectomy. And third is Young's perineal prostatectomy. Clear? This question was asked long back in Andhra PG, that out of these 3 which one is obsolete. So see, it's the Young's perineal prostatectomy which is obsolete. It's obsolete. How to remember? Young is very old. So Young is very old, it's obsolete. So Young's perineal prostatectomy, it's obsolete. Second question. See, if a patient is having bladder stone and bladder diverticula, means patient is having bladder pathology. And if the patient is having bladder pathology, out of Freyr's suprapubic and Millin's retropubic prostatectomy, which one is used? So obviously we will go for Freyr's suprapubic prostatectomy, because we can treat stone diverticula simultaneously we can perform what? Prostatectomy. So these are the types of open prostatectomy. For the treatment of BPH we can use laser also. In renal stones also we use laser. So which laser is used for BPH and the treatment of renal stone? It is the holmium-Yaag laser, also known as HO-Yaag. So which laser is used? You have to remember it's the HO-Yaag laser, right? And it is used in BPH and it is used in the treatment of renal stones. Renal stones, right? So this is how we manage the BPH. Before discussing acute bacterial prostatitis, let me tell you basics first related to infections in genitourinary tract. It's very easy to understand. This is kidney, this is ureter, this is bladder, this is prostate, this is urethra, this is vas deferens and testes. Okay, very important point. What is the most common hospital acquired infection? And the most common hospital acquired infection is UTI. So the most common hospital acquired infection is urinary tract infection. Okay, what is the most common organism responsible for UTI? And the most common organism responsible is E. coli. Right, now see, patient is having UTI and now this E. coli is going into urethra and it is reaching which urethra? It is reaching the prostatic urethra. When organism reaches prostatic urethra, it can cause what? Acute bacterial prostatitis, chronic bacterial prostatitis and prostatic abscess. So for acute bacterial prostatitis, chronic bacterial prostatitis and prostatic abscess, what is the most common organism responsible? E. coli. So here you can see acute bacterial prostatitis, chronic bacterial prostatitis and prostatic abscess. And what is the organism responsible? This is E. coli, right? Now see, via this ejaculatory duct, the organism is reaching the vas deferens and then involving the testis. Clear? So if only epididymis is involved, patient is going to develop epididymitis, and when epididymis and testis both are affected or involved, patient is going to develop epididymoarchitis. So acute epididymoarchitis in children, in elderly and in homosexuals. In all these cases, what is the organism responsible? It is E. coli. So if the patient is having acute epididymoarchitis, especially in children, in elderly and homosexuals, right? Children, elderly and homosexuals. What is the most common organism? E. coli. Third problem, imagine the patient is having vesico-ureteric reflux. So if the patient is having vesico-ureteric reflux, can you see via ureter this organism is reaching the kidney, and if the organism reaches kidney, there is inflammation of kidney, that is known as pyelonephritis. So if the patient is going to develop acute pyelonephritis, chronic pyelonephritis, emphysematous pyelonephritis and perinephric abscess, what is the organism responsible? E. coli. So here what it can do, here there can be acute pyelonephritis, there can be chronic pyelonephritis, there can be emphysematous pyelonephritis and perinephric abscess. Perinephric abscess. And in all these cases, what is the most common organism responsible? And that's E. coli. So what is acute bacterial prostatitis? It is nothing. It's the acute inflammation of prostate associated with urinary tract infection. And what is the organism responsible? E. coli. So we are going to discuss in detail acute bacterial prostatitis. It is acute inflammation of prostate associated with UTI, and the most common organism is E. coli. Whenever there is inflammation of prostate, these patients are having fever with chills and rigor. Simultaneously, patient is also having irritative symptoms. And whenever you are going to perform the digital rectal examination, obviously there is inflammation, so prostate is tender, it is boggy and enlarged. So see the clinical features. These patients have fever, there is Chilson rigor, there is presence of irritative symptoms, and whenever we perform digital rectal examination, the prostate is enlarged, it's tender and boggy. Enlarged, tender and boggy, right? Since there is infection, obviously we have to treat the infection with the help of antibiotics, and generally you have seen that for how long we are giving antibiotics in UTI, generally for 7 to 10 days usually. But if patient is having acute bacterial prostatitis, the antibiotics are given for very long duration, and that's 4 to 6 weeks. So here we have to treat it by antibiotics. And antibiotics we give trimethoprim, sulfamethoxazole or ciprofloxacin. So the antibiotics used trimethoprim, sulfamethoxazole or ciprofloxacin, and this is given for 4 to 6 weeks. You have to remember the duration. But what is the problem? Whenever patient is taking antibiotics and after 5 days, 6 days, 7 days, there is improvement of symptoms. So whenever there is improvement of symptoms, some patients are going to leave the antibiotics. They are going to discontinue the treatment. And if the patient is going to discontinue the treatment, there is no eradication of infection. It means infection is still there and infection is persistent. This persistent infection inside the prostate is known as chronic bacterial prostatitis. Clear? So whenever there is persistent infection, this is chronic bacterial prostatitis. Meanwhile, what happens in these cases? Patients have their period of no symptoms and then patient have recurrent UTI. So what happens? In chronic bacterial prostatitis, there is persistent infection, and because of this persistent infection in prostate, these patients have recurrent UTI. Now here the big problem is first to diagnose it and second to treat it. So how we are going to diagnose it? See, we have to take prostatic expressate and urine for culture, and this prostatic expressate and urine is taken for culture before performing the prostatic massage and after performing the prostatic massage. See, if patient is having acute bacterial prostatitis, you can perform digital rectal examination, but prostatic massage and catheterization is contraindicated. In which case, acute bacterial prostatitis, prostatic massage and catheterization is contraindicated. But if the patient is having chronic bacterial prostatitis, we take prostatic expressate and urine for culture before performing the prostatic massage and after performing the prostatic massage. So how we are going to diagnose it? We perform culture and sensitivity of prostatic expressate and urine, right, before and after massage, before and after prostatic massage. Clear? And on the basis of culture and sensitivity report, we have to give antibiotics for longer duration of time. How much duration? We have to give the antibiotic for 3 to 4 months. So the treatment here, antibiotics are given for 3 to 4 months. So antibiotics are given for 3 to 4 months. Now certain patients of acute bacterial prostatitis, suppose they are not coming to you or they are not going to continue the treatment for adequate period of time. In those patients, what's the problem? There is formation of abscess. So there is pus collection and this is known as prostatic abscess. So prostatic abscess, which is a complication of acute bacterial prostatitis. Prostatic abscess, it's a complication of acute bacterial prostatitis. But what is the problem? In prostatic abscess, fluctuation is a late sign. This is also one important point. In prostatic abscess, fluctuation, it's a late sign. Generally, in which cases we see prostatic abscess? If the patient immunity status is compromised. So generally, what are the predisposing factors for prostatic abscess? The predisposing factors, very important. What? Diabetes mellitus, immunocompromised patients, if the patient is having renal insufficiency, and if patient is having catheterization, catheter in situ for long duration, so chronic catheterization. Clear? How we are going to diagnose this? Since there is pus collection in relation to prostate, you can diagnose it by TRUS. What is TRUS? Transrectal ultrasound. Since you are performing digital rectal examination for evaluation of prostate, so you can perform TRUS, you can see that prostatic abscess, or you can go for pelvic CT. So how we are going to make the diagnosis? Either by TRUS or by pelvic CT. Okay. We discussed that if pus collection is there in the body, generally it should be drained and we have to give antibiotics. Now what is the route of drainage? Okay, now see, this is urethra and prostate is around urethra. So what we are going for? Transurethral drainage. So we are going for transurethral drainage and we give antibiotics. So the treatment is the transurethral drainage plus antibiotics. Next important topic is prostatic stone or prostatic calculi. Okay, so see, prostatic calculi. So what is this prostatic calculi? It is nothing, it's calcified corpora amylacea, right? And what is the composition? Calcium phosphate. So this prostatic calculi is calcified corpora amylacea. Okay, and what is the composition? It is calcium phosphate. Right? What is the most common site of this prostatic calculi? So if you see this diagram, what happens? This zone is transition zone, right? So generally the location of this stone is periphery of transition zone here. Where? Here. So if the question is asked, what is the most common site of prostatic calculi? Which zone? Is the transition zone. And in transition zone, exactly where? Periphery. So the most common site is the periphery of transition zone. Is the periphery of transition zone, right? And in majority of cases, it is asymptomatic. So generally no treatment is required. Now we are going to discuss very important topic, and that is carcinoma prostate. So carcinoma prostate, okay. You know that prostate is a gland, right? And if malignancy is arising from gland, so what is the most common histological type? It is adenocarcinoma. And we discussed that generally adenocarcinomas are more common in high socioeconomic status or low socioeconomic status. So it is more common in high socioeconomic status. And you must be knowing that the people belonging to high socioeconomic status, they have longer life expectancy and there is high fat diet. Clear? So see the important point related to CA prostate. The most common histological type is the adenocarcinoma, followed by transitional cell carcinoma. It is generally seen in high socio-economic status, generally seen in Afro-Americans. Okay. Generally, in which decade carcinoma prostate is seen? So it is seen in 7th to 8th decade, and we discussed two malignancies are seen in 7th to 8th decade. One is anaplastic carcinoma thyroid and second is carcinoma prostate. So it is seen in 7th to 8th decade. And what are the two malignancies which are seen in this decade? One is CA prostate and second is anaplastic carcinoma. Anaplastic carcinoma thyroid. Okay. Now, what are the risk factors? Patient belongs to high socioeconomic status and there is longer life expectancy. So the two risk factors are advancing age and second is high fat diet. So the risk factors are advancing age and high fat diet. Okay. What are the risk factors? These are the risk factors. What are the protective factors? So if patient is taking antioxidants in any form, that is protective. So the mnemonic LISA is protective. So what are the protective factors? Protective factors, and the mnemonic is LISA. Generally, there is increased intake of antioxidants. So L, lycopene. Lycopene is in tomato. The rich source is tomato. E means vitamin E. S means selenium. And A means vitamin A. Clear? So these are the protective factors. So we already discussed that what is the most common site of carcinoma prostate. It is located in peripheral zone, but it can be seen in transition zone as well as in central zone. Most commonly peripheral zone, how much is the incidence? 75%. In transition zone 15%, and in central zone it's 10%. That's why majority of patients are asymptomatic. Why? Because it's located in the peripheral zone, right? Second question, this is asked in pathology, that what is the most common genetic alteration seen in CA prostate? And this is hypermethylation of GSTP1. GSTP1 means glutathione transferase promoter region 1. So most common genetic alteration, the most common genetic alteration in CA prostate is hypermethylation. It's hypermethylation of GSTP1, glutathione transferase promoter region 1, and this is located on chromosome number 11. Then in pathology, another question which is asked, that what is the difference between benign and malignant glands? So see, in malignant glands there is rapid division, and because of that what these glands are relatively small, crowded and lack branching. So malignant glands, what are the features? These malignant glands are small, crowded, lack branching, and the most important feature is that there is absence of basal layer. Absence of basal layer, this you have to remember. There is absence of basal layer. Now see the clinical features of carcinoma prostate. We discussed that most common site of carcinoma prostate is peripheral zone, and that's why majority of patients are asymptomatic in initial stages, right? When the patient is having metastasis, most common site of metastasis is lumbar vertebra. So because of metastasis to lumbar vertebra, these patients are coming to us with backache, and generally these patients are going to which particular department? Initially ortho, department of orthopedics, and when further investigation is being done, then the primary is detected where? In the prostate. Okay, so see the clinical features. Most patients are asymptomatic. So most patients are asymptomatic in initial stages. Later, when there is advanced and metastatic disease, patient comes with backache, right? And why backache? Because the most common site of metastasis is lumbar vertebra. So there is involvement of lumbar vertebra. Okay, there is lymphatic spread also, lymph node metastasis also. So which group of lymph nodes are most commonly involved? Pelvic. And in pelvic, which one? Obturator. So there is lymph node metastasis, and most commonly involved group, it's pelvic. And in pelvic, this question is asked, in pelvic, which particular group? Obturator. Obturator. Right? Lots of questions are asked related to bone metastasis. Now see, in carcinoma prostate, what kind of secondaries are there in lumbar vertebra? There are osteoblastic secondaries. So the most common primary for osteoblastic secondaries in males is carcinoma prostate, and the most common primary for osteolytic secondaries in males is RCC. And the most common primary for both osteolytic as well as osteoblastic secondaries in females is carcinoma breast, right? In CA breast and CA prostate, the most common site of metastasis is lumbar vertebra. This is clear. Now, most common site of visceral metastasis. So in CA prostate, what is the most common site of visceral metastasis? And that's lungs. So most common site of visceral metastasis. So that's why you have to read the question carefully. If it's visceral metastasis, then it's lungs, right? Now coming to the investigations. Whenever these patients are coming to our OPD, what we perform after taking history? We perform digital rectal examination, and on digital rectal examination, here prostate is enlarged, it's hard, and there is median sulcus obliteration. So on digital rectal examination, prostate is enlarged, it's hard, and there is median sulcus obliteration. Right? Now we have to perform the biopsy for confirmation, and via which route we are going to perform biopsy? See, we are going to perform digital rectal examination for palpation of the prostate. So same route is used for taking biopsy. So which type of biopsy is performed? It's the truss guided biopsy. What is truss guided biopsy? It's the transrectal ultrasound guided biopsy. Okay, so investigation of choice for diagnosis is truss guided biopsy. We discussed that in head and neck malignancies and in pelvic malignancies, there is overcrowding of soft tissues. Soft tissues means nerves, vessels, muscles. So whenever there is overcrowding of soft tissues, for staging of such regions, MRI is investigation of choice. And that's why investigation of choice for staging of head and neck malignancies and pelvic malignancies like CA prostate, CA rectum, CA bladder, which investigation is used? MRI. So here the investigations used. First question, investigation of choice for diagnosis, and this is truss guided biopsy. Truss guided biopsy. First, investigation of choice for staging. Investigation of choice for staging, we go for MRI, and the special type of MRI, that is endorectal coil MRI, right? So these are the investigations which are done. Nowadays certain new questions are asked related to carcinoma prostate, and one of that topic is ProstaScent. What is this ProstaScent? This is antibody imaging for carcinoma prostate. So a new topic, relatively new. What is ProstaScent? Clear? So this is antibody imaging used for carcinoma prostate. What kind of antibody imaging? This is the monoclonal antibody imaging used for carcinoma prostate, and it is against which antigen? It is against prostate specific membrane antigen. So what is this ProstaScent? This is the radio labeled monoclonal antibody imaging. So this is antibody imaging against carcinoma prostate. So we use radio labeled monoclonal antibody against prostate specific membrane antigen. Prostate specific membrane antigen, right? Now, what is the advantage? Suppose a patient is having biopsy-proven carcinoma of prostate, in which diagnosis has already been done. In those patients, we have to detect soft tissue metastasis and lymph node metastasis. So this is used. Prostate advantage. So if a patient is already having biopsy-proven carcinoma of prostate, in these patients, what we are going to detect? Soft tissue and lymph node metastasis. So in these patients, we are going to detect soft tissue and lymph node metastasis with the help of this prostate. Second, tumor marker. Okay, so what is tumor marker? It's the marker of tumor. Tumor marker is the marker of tumor. So when some evidence of tumor is there in the body in the form of primary or in the form of secondary, these markers are raised. Tumor markers are helpful in diagnosis, but their main role is monitoring the response of therapy after tumor removal. Okay, so what are the tumor markers which are used in carcinoma prostate? So tumor markers, this list is important, asked in surgery and pathologies. First is prostate specific antigen. So prostate specific antigen. Second is prostatic acid phosphatase. Third, alkaline phosphatase. Fourth, alpha methyl CoA racemase. Alpha methyl CoA racemase. There is hepsin and DD3. Clear? These are the markers. Out of these, which one is most important? The most important is prostate specific antigen, PSA. Now what is the name? Prostate specific antigen. So this term is self-explanatory, that this marker is prostate specific, not the cancer specific. What does it mean? It means that it will be raised in both benign as well as malignant conditions. Why? Because it is prostate specific. So first important point related to PSA, it is prostate specific, not the cancer specific. And since it is prostate specific, it is raised in benign conditions also. Benign conditions also means you perform digital rectal examination, it is raised. You perform catheterization, it is raised. You perform prostatic massage, it is raised. In bacterial prostatitis, it is raised. Clear? Simultaneously, it will be raised in carcinoma also. What is the normal value of PSA? So the normal value of PSA is less than 4 nanogram per ml. Less than 4 nanogram per ml. Okay. Then which value is diagnostic of carcinoma prostate? If it is more than 20 nanogram per ml, this is diagnostic of carcinoma prostate. Okay. There are two terms which are asked. One is PSA density and second is PSA velocity. So what is PSA density? It is the PSA divided by prostate volume. PSA divided by prostate volume, that is density. And what is PSA velocity? It's the rate of change of PSA. Okay. So two terms. One is PSA density. Clear? So this is PSA, prostate specific antigen, divided by prostate volume. Prostate volume. Okay. Whenever PSA density is more than equal to 0.15, if it's more than equal to 0.15, it is suspicious. Means there is suspicion of malignancy. And whenever there is suspicion of malignancy, if the value is more than equal to 0.15, what is recommended? Biopsy is recommended. Why? Because there is suspicion of malignancy. More important than PSA density is PSA velocity. Why? Because one value of PSA velocity is diagnostic of carcinoma prostate. So what is PSA velocity? It's the rate of change of PSA. Which value is diagnostic? If it's more than 0.75 nanogram per ml per year. PSA velocity more than equal to 0.75 nanogram per ml per year. This is diagnostic of carcinoma prostate. Okay, so the three questions which are very important, frequently asked, you have to remember: normal value of PSA less than 4 nanogram per ml. Which value is diagnostic of carcinoma prostate? More than 20 nanogram per ml. And which value of PSA velocity is diagnostic of carcinoma prostate? More than 0.75 nanogram per ml per year. Clear? So this is diagnostic of carcinoma prostate. Now we are going to discuss 8th AJCC TNM classification for carcinoma prostate. Okay, so 8th AJCC TNM classification, right? So first is TIS. TIS means carcinoma in situ. So TIS, so this is carcinoma in situ. Okay, after that T1. T1 is further divided into T1A, T1B, T1C. Now what is T1A, T1B, T1C? Suppose a patient is having BPH, okay, and you are performing what? TURP, transurethral resection of prostate, and the specimen is sent to which department? Pathology department. In the specimen sent to the department, what if up to 5% tissues are having the evidence of malignancy or cancer? This is T1A. And if more than 5% of tissue is having evidence of cancer, this is T1B. And whenever we are going to make the diagnosis on needle biopsy, this is T1C. So what's T1A? Up to 5% of tissue removed in resection for benign disease has cancer. And T1B, if more than 5% tissue removed during dissection for benign disease has cancer. And in these patients, digital rectal examination is normal. So despite of normal digital rectal examination, up to 5% tissues resected for benign disease has evidence of cancer, it is T1A, and more than 5% tissue is having evidence of cancer, that is T1B. In T1C, the tumor is identified on needle biopsy. Tumor identified on needle biopsy. T2 is further divided into T2A, T2B, T2C. In T2A, the tumor is involving one half of the lobe. And in T2B, when more than one half of the lobe is involved, and in T2C, both lobes are involved. So see, T2A, T2B and T2C. In T2A, tumor involves one half of the lobe. In T2B, involve more than one half of the lobe, and in T2C, both lobes are involved. T3 is divided into T3A and T3B. What happens in T3A? In T3A, there is extracapsular extension, and sometimes there is involvement of bladder neck also. So if there is extracapsular extension or involvement of bladder neck, this is T3A. And in T3B, there is involvement of what? Seminal vesicle. So T3A. In T3A, there is extracapsular extension on one or both sides. Okay, including bladder neck. Including bladder neck. And what happens in T3B? There is involvement of seminal vesicle. So T3B, involvement of seminal vesicle. Now T4. In T4, the tumor is fixed, or it is going to involve the structures other than seminal vesicle. So in T4, the tumor is fixed or it invades structures other than seminal vesicles. Other than seminal vesicles. So which structures can be involved in relation to prostate? Like external sphincter. There can be involvement of rectum because it's in close relation, and there can be involvement of levator muscle of pelvic wall. Levator muscle and or pelvic wall. Clear? So this is T. Now see the lymph node staging. N0 means no metastasis to regional lymph nodes. Okay, so N0, there is no metastasis, and you have to remember what? Not lymph node, it's regional lymph node, because if non-regional lymph node is involved, it is considered metastasis. Okay, so what is N1? There is metastasis to regional lymph nodes. Metastasis to regional lymph nodes, right? So which lymph nodes are included? We discussed that the most common site of metastasis is pelvic lymph nodes, pelvic group, and in pelvic, which one? Obturator. So it can be involvement of which one? Obturator, internal iliac or external iliac. So internal iliac, external iliac lymph node, or presacral. So in metastasis, M0 is no metastasis. And what is M1? M1 is further divided into M1A, M1B, M1C. In M1A, there is metastasis to non-regional lymph node. In M1B, there is metastasis to bone, and in M1C, there is metastasis to other sites. Okay, so see, in metastasis, M0, M0 means no metastasis. M1 is divided into M1A, M1B, and M1C. Okay, in M1A, there is metastasis to here you have to remember non-regional lymph node, right? So this is non-regional lymph nodes. Okay, M1B, there is metastasis to bone, and in M1C, metastasis to other sites. Clear? So this is 8th AJCC TNM classification for carcinoma prostate. Now we are going to discuss the management. So see the management of carcinoma prostate. What is the good thing about carcinoma prostate? That it's a slow growing tumor, and if the patient is having early stage like T1A, it takes generally 10 long years to become fulminant. So if a patient is having which stage? T1A, what is recommended? Nothing. Observation and follow up. And how we are going to follow up this patient? By DRE plus PSA for T1A. Now if the patient is having T1B, T1C, T2, the stages T1B, it is T1C or T2, and the age of patient, this question was asked in names. If the age of patient is more than 70 years, I told you it takes long time to become fulminant. So in these patients also, what we go for? Observation and follow-up. So we go for DRE plus PSA. But if the age of patient is less than 70 years, here patient is relatively young, and in this case we can go for radical prostatectomy. Here we can go for radical prostatectomy, and the second option we have is radiotherapy. Which one is preferred? Radical prostatectomy is preferred. There are certain patients in whom surgery is contraindicated, patient is not fit for anesthesia. In those cases, we may go for what? Radiotherapy. Now, if the patient is having advanced malignancies like T3 and T4, the stages T3 and T4, in these cases, hormone therapy is preferred over radiotherapy? We discussed that prostate is under the influence of which hormone? Testosterone. So we are going for androgen ablation. So how we can go for androgen ablation? We can go for bilateral orchidectomy, or we can use LH-RH agonist. So for T3 and T4, the preferred strategy is what? It's the androgen ablation. This androgen ablation is preferred over palliative radiotherapy. It is preferred over palliative radiotherapy. How we go for androgen ablation? Bilateral orchidectomy plus flutamide. Okay, and if patient doesn't give the consent for orchidectomy, or what is the other alternative? We can go for medical orchidectomy with the help of LH-RH agonist and flutamide, right? This is the famous question of AIIMS, that which LH-RH agonists are used. These are also used in CA breast. So one is goserelin and the second is leuprolide. So it's the goserelin and leuprolide, and this is the famous question of AIIMS. It was asked 4 to 5 times in AIIMS, that which of the following is, or which of the following drug is recently FDA approved for advanced and metastatic carcinoma prostate, and that is goserelin. So recently FDA approved for advanced and metastatic carcinoma prostate. If you remember, there was one question in NEET super specialty that there are 2 new drugs approved for castration resistant metastatic carcinoma prostate. So what are the new drugs for castration resistant carcinoma prostate? You have to remember, because this was asked in exam. First is cabazitaxel and second is sipuleucel T. So it's the cabazitaxel and second is sipuleucel T. Frankly speaking, this sipuleucel T is a vaccine. So this is a vaccine, right? So these are used for castration resistant carcinoma prostate. Castration resistant means which is resistant to orchidectomy or hormone therapy. After that, there is a question which was asked many times in AIIMS and various other entrance exams. What is the most commonly used histological grading system in carcinoma prostate? Most commonly used histological grading system, and you must be knowing the name is Gleason grade. Now there are 2 terms. One is Gleason grade and one is Gleason score. See the concept. First, what is Gleason grade? Gleason grade is the most commonly used grading system for carcinoma prostate. Now see, suppose I'm going to take biopsy from carcinoma prostate and there are 2 most predominant histological patterns. Okay, those 2 most predominant histological patterns are graded from 1 to 5. So this is divided into 2 types. One is primary grade and one is secondary grade. This primary grade is for most common histological type and the secondary grade is for second most common histological type. Okay, and what is the range? The range is from 1 to 5 and from 1 to 5. So 2 most predominant histological patterns are assessed, further divided into primary and secondary, and the grade ranges from 1 to 5. Now, what is the Gleason score? Gleason score. So Gleason score is sum of primary plus secondary grade. So if you are going to add 1 to 5 plus 1 to 5, the Gleason score ranges from 2 to 10, and this question was asked in AIIMS. That Gleason score ranges from 1 to 10. This is correct statement or incorrect statement? So obviously this is incorrect statement because Gleason score ranges from 2 to 10. There might be some hypothetical question. Suppose the Gleason score is 7. There are two variations. One is 4 plus 3 and second is 3 plus 4. Tell me which one is having poor prognosis. So see, if the primary grade is higher, it is having poor prognosis in comparison to secondary grade, which is higher. So here 4 plus 3 means 4 is for primary grade and here 4 is for secondary grade. So obviously this one will be having relatively poor prognosis. Clear? There are various named stagings which are used in urology. Example, there is a Robson staging. Robson staging. So this Robson staging is used for what? RCC. There is Jackson staging. Jackson staging is for carcinoma penis. So Jackson staging, this is for carcinoma penis, and we discussed there is Gleason grading. There is Gleason grading, and this Gleason grading is for CA prostate. Right? So what is the similarity between these? Sun, sun, sun. Clear? So these are used for urological malignancies. Robson for RCC, Jackson for carcinoma penis, and Gleason for carcinoma prostate.